CTO.
2 months back with mild LV dysfunction, EF around 40%. CAG revealed triple vessel disease. As you can see in this angiography, there is a mid-segment L6 obstruction of 100%, which was stented with a good end result. RC had a discrete lesion in the mid portion, which was again stented with a good end result. Right now, our plan is to take care of the LAD, which you can see here as a proximal occlusion of 100%. And we plan to open it. We have a good proximal early diagonal branch in this case. We'll go live now.
Okay.
Saito sir, your mic on, sir.
Yeah, you are on,
Yes.
sir. You are on.
Okay. Okay. Can you hear me?
Yes, very well.
Okay. This is a patient after the recanalization of circumflex acute myocardial infarction, and the patient has this kind of subtotal occlusion in proximal LAD. Okay. So this is the target today. I want to take the XTA with microcatheter. Yes, microcatheter, 135, yeah.
એકાદ બે ચાલશે સાંભળો એકાદ બે પ્લેસ ચાલશે પછી કન્ટિન્યુઅસ પ્લેસ ના પાડતા
Can you expand on your strategy for us? So it's a single access, 7 French radial, is that,
Yeah,
or 6 French?
6
radial?
French.
And your plan is a microcatheter and antegrade field to XTA?
Yeah,
નિરલ
introducer. Okay. Okay. Okay.
Saito sensei.
Yes.
Yes, I'm Akasaka speaking.
Yes.
Yeah, for me, it is not so difficult.
Get the tip.
Difficult for you to perform PCA, but are there any wonderful tips and tricks for the beginner in this case? Could you give us yes a suggestion?
Okay, it's very important. Okay, actually, this case is not a real CTO case. It's 99% of narrowing. However, in turn, that means the most narrowest part should be not so hard, very easy to be penetrated. So the important tips is we have to take the not so much stiff wire. Okay.
Okay.
And the second one is if you are taking not so much stiff wire in this kind of case, it might be very difficult to cross the region because of the wire is not so stiff. So then it is better to take the hydrophic coating wire to reduce the friction between the wire and the vessel.
Yes.
Okay, so the best choice in this situation is to take the XTA wire
Okay.
from Asahi.
All right.
And of course, we have to get some kind of manipulation ability. That means we need a microcatheter. So I'm starting from the combination of microcatheter, that is Caravelle,
Carabel, yes.
and XTA.
Okay.
Both are Asahi products.
Okay.
Okay?
Thank you.
Okay. The tip of the wire is in LAD.
Yes.
Okay, this is at the point of most narrowest part.
Yes.
Then I'm keeping the wire just in place here.
Yes.
The tip is not moving, and then I'm pushing gradually, pushing the micro catheter into the vessel.
Yeah.
Okay.
Okay.
Then I try to cross this vessel. Okay, crossed. But don't push too fast, because sometimes the wire is very easily creating the dissection. So it's very important. And okay, the wire is very easily going to the septal branch. This is in the main lumen. Okay. As far as possible, I want to push this wire deeply into the distal vessel, because it increases, support of any device over the wire. Then maybe I can continue to use this wire. However, there is some risk of making perforation
Yes.
by the tip. So I want to exchange the wire to the workhorse wire.
Okay.
What is it?
Run through.
Run through, okay, run through. So I have to cross this microcatheter through the region.
Yeah.
Okay, I tried. I'm keeping the wire just in place and try to push, but cannot do it. Okay, then the situation is different, because I cannot cross microcatheter. So it might be difficult to exchange the wire. In that case, we have a different choice of strategy.
Yes.
This is a 6 French, so I may take the anchoring balloon. That means I put another wire to some proximal branch, and then put the balloon there and inflate the balloon in the proximal branch. It fixes the guiding catheter into the left coronary artery. However, please look at the anatomy. I cannot find any proximal branch.
Yes.
So anchoring balloon may not work. So in this case, the easiest way is to take 1 point, the smallest size of balloon,
1.25.
1.25. And however, I have to remove this microcatheter from the coronary artery, and then, because this is a hydrophic stiff wire, slippery wire, so it is very difficult to remove this microcatheter by using this, how to say,
Impression device.
by pushing the
Continuous
end
compression,
by
maintain the continuous pressure.
compression
Yes.
device. So if this is not a stiff wire, a hydrophic wire, I can just connect and then push by this manifold. However, it's very dangerous. It may push the wire, slippery wire, deeply into the coronary artery, and then may make a perforation.
Yeah.
So the way how to do it is just I want to put the 2.5 millimeter balloon
Okay.
here.
2.5.
That is a trapping technique.
Yeah.
2.5, anyone.
12. 12.
15,
12,
15,
12,
15.
15.
Okay?
Yes. My simple question is, there are lots of microcatheter. Why Saito Sensei choose the caliber in this case?
Because somebody, posted me.
Very simple reason, right?
Yeah, yeah.
Okay.
Okay, this is a simple 2.5 millimeter balloon. We don't need any wires. Just push this. Huh? Cannot? Oh yeah. Okay, just push this balloon. And can you see the
It's still not come.
marker? Not yet.
Not it. Not it. Balloon. Show me balloon.
Hmm.
Yes.
Okay, coming. The balloon is coming. Okay, maybe here you can inflate. Yes, please.
For
At 6.
6.
Okay, this is anchoring the wire within the guiding catheter. So by keeping this maneuver, I can safely remove the microcatheter while keeping the wire still in position. Okay, I'm putting back the microcatheter. Okay, it's safe procedure. However, it is better to make everything very slowly. Okay, now I got the wire. And then next, deflate. And I remove this anchoring balloon, trapping balloon. And then I'm waiting for the blood air came back. Okay. So now this wire is single, alone in the LAD. So next step is to take the
Shortest
smallest size of balloon.
1.25 balloon.
Yeah. Any question?
Any question from the panel or audience?
With 10 or 15? Which you want? 10, 15?
15?
15.
1.5?
1.25.
How about 2.5?
Okay.
Oh, okay, 10. 1.25. So we have a 1.25 millimeter balloon. So I'll take it.
You want to use IVAS or anything else?
IVAS, yes. IVAS, please open the IVAS. Okay. Can I see the tip?
Tip. Wire tip.
Okay. The balloon is coming. Okay, the balloon is coming. Oh, still some resistance.
Oh, it's gone.
Okay, close. Okay, here. Yeah. Might be. It was more difficult than I have expected. Okay.
Going again.
Yes, here. Okay. Test. Yeah. One more. Okay, here. 16. Okay. Okay. Okay, shall we take a picture?
Yes, we go ahead.
I think
This bigger size balloon?
yes, 2.5.
No, previous balloon.
2.5, 15. The previous one,
Ah,
previous anchor balloon is 2.5, 15. I take it to pre-dilate. Then I will do IBUS. Then place a stand. Okay. Okay, here.
going again.
Yeah. Okay. So shall we take angiography? Okay.
Okay.
So this XTA is very thick in density. So it is very difficult to evaluate the region from angiography. So I want to change the wire.
Okay.
Okay. So can I
Run
have
through.
run through, please?
Panel આ બધું લઈ લઈએ.
This one.
I gave it to needle.
Needle. Shape needle. Yes. Okay. Okay. So shall we do IBUS?
Take a picture.
Okay. Have you given nitro?
Yeah. Nitro.
Do we have any pictures of the left LAD origin? Are we going to stand all the way back to the left main? Is that the plan, or will you use IVUS to help guide that?
Yes, after IBUS. I will decide. Okay, IBUS.
Consider intracoronary nitroglycerin before
Yeah.
IOS, please.
Yes. Okay. We have given the nitroglycerin. Okay. Maybe from here. Okay. Start.
Start.
This is a quite normal portion. No.
Yeah. Could you show us the IVUS?
Somebody.
Could you show us IVUS? IVUS.
Can you see?
Okay, yes, now we can see,
Ah,
yes.
okay. From my standing point, it's very far to the IVUS screen.
It's a very,
Okay, the region is starting.
yes.
No?
It's a branch, yes, comes in, yes.
Diagonal.
Diagonal, yes. The only small amount of calcium, but mainly fibrous. Yeah.
Yes. The vessel is 1 to 3 millimeter,
Ah, yes, yes.
and this plaque. Some clarification.
Yes.
It's and we have to check the osteal LAD
Yes.
as well.
Now coming.
Yeah,
yes.
some plaque.
Yeah. It continued to the left main, right? Yeah.
Oh, this is a left main.
Yes, this is the left main.
Left main. So the previous one was SAC. At the 6 p.m. at 6 o'clock, we could see SAC. This is still left main body. Okay, I stop. So could you repeat playback?
Repeat.
And I want to take a picture of spider view. Spider view to check the LAO caudal.
LAO caudal.
Is it possible? Okay.
It's okay. वो कॉल निकल जाता.
Okay. Ah.
We have a big diagonal,
Big
right?
diagonal.
Right.
Yeah. So it's a question how to place a stand. Yes? Yeah? Ah, okay, thank you. Just a moment. Okay. So how you okay. could you repeat? Yes, at the ostium of LED, there is a big bifurcation.
This is the picture.
Ah, this is the original picture. This is after two, no. Next one is after 2.5 millimeter balloon dilatation. This is IVAS. This one, after 2.5 millimeter balloon dilatation. So the problem is big diagonal. Yeah. Ready? Yeah. Yes. So, can I have one more wire?
Which one?
Workhorse, regular.
Run through. So we give one wire and the wire.
Hmm.
To stand. Crossover or just
Okay. I place another wire to proximal diagonal artery, and then place a stand from LAD to LAD. Just, crossovering the diagonal. Just. This is okay. So,
okay. Saito sensei plan to put a stand cross over the diagonal, right?
yes,
The size of the vessel of LAD and diagonal is equivalent, or
Yes.
diagonal is little
Bigger,
bit bigger, right?
Yes, yes.
But after some time of total occlusion, LAD might be a shrink. Yeah, so nearly equivalent, right? So
Yes.
yeah. And also by angio, the angle of LED and the diagonal is very narrow, so there are some risk of the pinch of the diagonal branch if you cross over the stent.
Yes.
So you are thinking about the kissing balloon after there are some pinch.
Yes.
Okay, thank you.
Yes. So the problem is the size of the stent. Now I'm thinking that the diameter should be 3O. And the length is, I don't know the length. Can you check by IBAS? Yeah. So from the normal part, yeah. Which one? Where?
It's distal one.
Distal is where? In the longitudinal
Yeah,
view.
this one.
Oh, that is too distal. Oh, already. Yeah, more proximal. Yeah. Can I see change the
Epicranial.
epicranial?
Epicranial.
No, before that. No. No, 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 no. No. No, after that. Yeah,
Yes.
yeah, this one. Actually, no branch, no diagonal. Only septal. Can you identify where is the septal branch?
Where is the septal branch? Can you?
That might be the septal.
That is septal. So from there to the
Proximal area.
proximal already. Diagonal, okay. More proximal, more proximal. Okay, around there.
Yes.
Which is 21,
31.
31
31.
length.
Yeah.
31, and the diameter is 4O at the proximal part. So, and but distal
Is
is
2.5.
2.5. So maybe I want to take 3O, 3O by 32?
32.
So-
3 or 32.
33 was that.
33.
How do you think?
I mean, this is really going to,
Yes, yes, on.
yeah, this is really going to be an issue. I mean, I heard you discussing that, you know, this has been occluded for a while. It just may be a much more narrow vessel now, but I think has room to grow. But I think the very proximal part, it clearly looks as though it's at least 3.540. And then the only other strategy that some people may think about is whether you stop the stent before the bifurcation. But I think in this case, it's probably better to cross the diagonal.
Okay.
That's what you're thinking?
Yes.
Yeah.
Yes, that's right.
And then you are measuring the length of this to that septal perforator, and so just in case they didn't hear at in the auditorium, so that was 31 millimeters.
Yes.
So you can put a 3.0 of
Yes.
31.
Yes.
Yeah.
3.0,
And then potentially, then you dilate up the more
Yes.
proximal part to
Yes.
4.0.
Yes,
Okay.
yes.
I think it's a very reasonable strategy.
Okay, thank you.
This is 3 or 33.
Okay.
Is there anyone in the panel there that would approach this differently? Just in terms of placement of the stent and the size of the stent?
I agree that the
There is some
cytosynthesis.
significant disease in that ramus or high diagonal. Why not a bifurcation culotte technique?
Culotte. Test. I don't like.
That's fine.
More booked. Okay. Here?
Take a picture.
Okay.
So in this case, I think there are a big size mismatch in the
Yes. Okay.
LAD
Yeah.
proximal
10.
and distal, and therefore the cytosynthesis selected the 3O, right?
Yes.
And gently put the stent to avoid the distal edge dissection, and then you try to do the part
Yes.
to adjust the size in the proximal, right?
Okay. Yes.
Okay, thank you.
So what was the pressure you in?
10 atmospheres.
10 atmospheres. So cautious dilation.
Yeah. And do you have 3.5 by 8
3.5 by 8 balloon.
balloon? Okay, shall we take a picture? Okay.
That's good.
6. Yeah, fine.
So I think we do see just a little bit of pinching of the
Yeah.
origin of that diagonal.
Yeah.
but otherwise it's good. So do you think that we expect if we get a good result here in the proximal LAD that in time that the mid and distal LAD, do you think that with the passage of time and better flow that this is going to be a bigger vessel?
After a time,
Yeah, more distally.
So this is a pot balloon, 3.5 by 8, 6. Okay, test.
You want to keep balloon in diagonal also,
Okay, here.
otherwise with the 3.5 it will increase more.
10, 12, 14, 14 atmospheres. Okay.
But it some start content difficult to balloon.
Okay, thank you. Okay, shall we take a picture?
wait.
Sorry.
Okay, good. That's good.
Yes, it's good. So I will do the crossovering of the wire. Okay. Exchange.
Some start is there. Huh?
And then oh,
Example of getting access into that diagonal by pulling the LED wire back and just letting it drop in there rather than trying to come into it antigrade.
so
So what is your plan now? To assess this further, or do you think it's going to need to be treated?
I want to do a kissing balloon at this moment. So we need 2 balloons.
Okay. Which size you want?
Maybe 3.
Would anyone on the panel approach this any differently?
302 LED.
What do you think about doing another
And the
IVUS to see
2.5.
the mechanism of pinching, to see how much is carinal shift versus plaque
Okay.
shift?
They recommend to do IBUS. Okay?
Okay.
Okay. So diagonal, first one is diagonal.
This is LED one. This one.
LED. So first do LED, IBUS.
Dr. Saito, do you think that further imaging is helpful here or not?
I don't know, but they request, so I will do.
Why don't they request it? They're just asking. I think you have to do what you
Yes.
think is best. But
I'm interested in. Anyway.
interested in it, yeah.
Yes, Saito Sensei, in this case, I think OCT is much better to identify the
Yes.
strut and wire condition. But
I understand, but in this room we don't have a
yes,
OCT.
yes, I know. Yes, therefore, after the pullback, you try to push in the IBUS at the site of the bifurcation, and we can confirm the wire position
Yes,
very
yes.
well, right?
Yes. Okay. This is going to LED, okay? From here,
Okay.
please rotate.
Rotate. Start.
Okay, starting here.
Can you see the ultrasound down there?
Just
2.5.
yeah,
2.5.
around the septal, yes. The position is the ideal as the Saito sensei plan, right?
Hmm.
And the yeah, symmetricity is very wonderful. Yeah, well expand. Here is
Yeah, coming close.
yes.
But I really want to expand more. Okay, this is the bifurcation.
Yeah.
The wire is
Wire
coming.
is coming in the proximal side,
Yeah,
right?
yeah, yeah.
So
And the wire is inside now.
yeah, yeah. Oh, right.
Okay. Just at the bifurcation to suck. Okay, so now, do you have any information why the pinch is occurring?
We could not see the longitudinal view, but
Mm.
there are no plug at the diagonal side. Therefore, the main cause of this pinch might be the carina shift,
Mhm.
right?
So I think at this moment, if I'm trying to cross the IVUS catheter to the diagonal, there might be some, catching of the IVUS catheter by the stent strut, so might be dangerous.
I think so. Yes.
Yeah. So now I want to take the 3O balloon and the 2.5 millimeter balloon together. Okay.
3O size is which size? Length?
15
3O 15 and
to 15 as well.
both 15.
Both 15. What do we have?
This is
Okay, okay, okay. So first I want to cross. That is the diagonal.
okay.
Yeah.
This is inflated balloon. Is okay for you?
I don't know.
Take
I
a
try.
2.5.
2.5. Okay.
And a 3,
3.
5. We have a 3 balloon. Okay. 3 both New York. 15.
15. No, 15.
15.
No. Okay. How about
NC
the
is regular
NC?
one? No
NC?
NC.
No?
No NC. Yeah.
Regular.
Hello. Sir. With we have a 2.5 12 NC immerse for diagonal. Okay, you want a 15
Okay,
one?
okay.
It's okay. For a diagonal.
Okay, first I want to cross that one.
Yes. This we have a 3.15.
And do you have another dilator?
Yeah. This is diagonal.
Okay. First, I want to close this one.
Could you show us the IVAS again? Yeah, try to check the wire position, right?
This is done.
Yeah.
Yes, yes, yes. The bifurcation, yes.
This is for LED.
Mhm.
Where is wire comes now, right? Yes, yes. I'm wondering wire is the proximal cell, right? Yeah, yeah, Saito Sensei.
Yes.
Yeah, I'm just wondering the wire of the side branch
Yeah.
just comes out the proximal side of the side branch, right?
Uh,
Boost there. That also differentiate very well.
Now the wire is move proximally slowly. Now yes, much slower. Yes, slower. Yes, yes. Now wire comes at the 6 o'clock, right? Yes, and then comes. Yes, still side branch comes. Yes, 6:15. Yes, comes. Yes, comes. Still, yes, under the stent strut, and then still under strut, and then comes out. Still under the strut, yes, and then still still under strut, and then comes out. Uh, yes, that's comes out, right?
And the question is, in this kind of situation, you know, the pinch is caused by the Carina shift.
Yes.
So it is a matter of the decision whether we have to cross the proximal or distal part.
I think if you have stent boost, that can also be applied here. Stent boost, you can see exactly the stent and balloon wire crossing also. Philips has stent boost. Philips.
Stent boost?
Yeah, stent boost. In that you can see the exact wire crossing, the
Okay,
balloon, the size.
we can
and
do
the-
stent boost here.
Yeah, it will be.
This is G machine.
Acha, okay, then
Is it possible?
Just a moment.
it is in the Philips.
So Akasaka sensei,
Yes.
the pinch is caused by the Carina shift.
Yes.
Okay?
Yes.
So in that kind of situation, still the short cine. Okay. Now,
Yeah. For a stand boost. Okay.
in this kind of situation, still the crossing where the wire is crossing, proximal or distal, is a matter of issue.
Yes, I think the distal is much better because we can avoid the metal carina.
I'm not planning to avoid the metal carina.
I see.
Because if it is a proximal, we can much more press the carina to the LED side. So, any information from, which, now in process. Still, we have to wait. Oh, this one, still wait. This is not the final. This is the final image. How do you think?
Can you see the stent boost images?
You can
the
see?
panel?
No.
Another view?
No,
The
we can't see.
You can see in epicranial view,
cranial view? Okay.
any other view. This is the best view. This is perfect view. This one is
Is it okay?
stand.
Okay.
Oh,
What?
he told me that size of the balloon and stand both are remain same one.
Really?
Yeah, this told.
Ah. I'm sorry, we cannot measure by using stent boost in this situation because we have changed the balloon from the delivery stent delivery balloon. Okay? So the next question is, as I asked Dr. Akasaka, it's still in this situation, it's a very important issue or not?
I think if, for example, if we dilate diagonal first, the metal carina shift to the LAD, and then if you dilate LAD, the metal carina back to the same position, right? So,
But
can you understand what I want to say? So the distal cell selection is much more important to do this kissing balloon. By IVAS, it is my understanding the wire is crossing the proximal cell.
So, in that situation, if I'm changing the crossing point from the distal to the proximal to distal, I have to take another wire while leaving this wire here.
Yes, or in our institution, we try to use an Crusade double lumen catheter. I'm not sure here you have or not, but
No.
it's very useful because there are two markers within 5 or 1 centimeter, I forgot, 5 millimeter. If we push in the double lumen catheter in the diagonal branch, we can identify the two markers and then pull back a little bit and then try to, insert the wire to the double lumen and select the diagonal. And then if we push in, it might be difficult to cross the two markers to the diagonal. That means
Can I have one more wire?
Which one?
overhanging
wire.
the stent strut.
Which
Yeah.
wire? Wire. No, guide wire.
You know, it seems a very sophisticated analysis and discussion of a problem that I think a lot of us are not faced with
true.
because we don't do a lot of imaging in this situation.
Oh, sorry.
So I'm curious from the panel, is this a situation that you wrestle with if you're imaging here in terms of the placement of that wire, proximal or distal?
This one is if we take in diagonal slightly bigger balloon and overlap that balloon with this LAD and both balloons are inflated simultaneously, there won't be any plaque shift. I think the debate can be on that also. If this diagonal balloon is also slightly bigger and or you can pull it and then inflate it simultaneously both balloons, then plaque shift will not be there. Even if the wire has gone in the start, it will make the wire stent morphology very according to the vessel.
I believe that's what Dr. Saito wanted to do initially until we persuaded him to do intravascular ultrasound. Sometimes we have just too much information, but it's
Yes.
it's been very educational for all of us.
Yeah, in the crossover technique, we try to select the distal cell as possible as we can, right? It might be better to have a good result. But by this IVAS, I can speculate the wire is in the proximal cell.
I think it was a very astute observation of yours. And I'm sure that that's what Dr. Saito was doing as he was pulling his wire back. You're hoping it would catch that distal cell.
There is disease in the mid and distal part of the diagonal as well. So any plans to fix that as well? Are you going to use a much longer stent to cover that distal lesion in the diagonal?
Dr. Akasaka?
Yes, yes.
Okay.
Yeah.
Can you store the image, fluoro image here now?
Yeah, Saito sensei
Can
selected the distal cell. Yes.
So, Dr. Akasaka, do you have any data comparing the distal cell selection or proximal cell selection?
Yes. Now there are data based on the OCT. Yeah. If there are lots of metal at the carina
This
site.
is diagonal. LAD?
Yeah.
This is LAD?
Yeah.
This is diagonal.
Diagonal.
Yeah.
Professor Akasaka, can I
No.
ask you in the meanwhile
No.
one question?
This is LAD.
Somewhere I read in some studies that
This
in the
is-
left main bifurcation, it may be okay to do the proximal crossing. In the non-left main bifurcation, it's always better to do the distal. Is any data there on that?
I think we are not
is,
separately
so
compared,
I
but
was again.
even in left main bifurcation or the non-left main bifurcation, if there are lots of strat on the carina side, there are some risk of restenosis. So that is the reason why we recommend to have distal cell selection. It makes a much better condition. Yes. Yeah, Saito sensei, it is only the Japanese registry based on OCT. Statistically, there are no significant difference at the moment because of the small number. That is the reason why the Dr. Shite want to have a much more bigger registry up to 600 to demonstrate the difference of distal cell selection and proximal cell selection. That is the reason why I'm just asking.
Okay, so we're looking at the ultrasound now, again after the wire is repositioned. Again, you can all see the ultrasound down there.
Yeah, wire comes, yes, 7 o'clock, right? And then, compared with previous condition, little bit, yes, distal, yes.
Okay.
So everyone is happy now.
Should be.
Should be.
So first I want to put the wire to diagonal, balloon to diagonal. Okay, diagonal. The 2.5.
And I believe with respect to that question about that more distal disease and that diagonal, I think the plan was just to do kissing balloon here. Is that correct, Dr. Saito?
Yes.
And only if there's a need to stent, I guess, would that be taken into consideration. So I think they were going to use a relatively short balloon here.
Yeah. This is 12.
Yeah.
2.5, 12. Okay, LAD.
So what size balloons are we using here then?
This
Yeah.
2.5, 12 in
2.5,
12.
12 in the
315
diagonal,
LED. 315 in LED.
315 in the LED.
Okay, because from I was finding, we have some room for further dilatation to the stent. You
Very
agree?
proximal part, for
No,
sure.
no, also the distal.
And the distal, yes.
So only LED first, okay, okay, yeah, to 16,
LED.
okay, 16, 1, 6, okay, deflate,
Deflate.
then come to the proximal, okay, another dilatation, 16,
16.
okay,
Yeah, and remembering it was only deployed at 10 atmospheres initially.
yes, and maybe the come to the this
Previous
projection.
view, this caudal. Hello, caudal. Arre.
This is the diagonal.
This is diagonal.
Test, please. Maybe it's fine. Wait, shall we take a picture? Okay. Okay, here. Go 12, 12.
Both 12.
Both 12.
12.
Here. Bubble.
This bubble.
Okay.
One more time.
Okay. Okay. Yeah. Deflate. And please check. More proximal. Okay, here. One more dilatation, maybe. Yeah.
12, 12.
12, 12. Oh, slipped. Okay, deflate. Maybe. Test, please. I think it's enough. Okay. Shall we do IBUS to LED?
This one is LED.
This one is LED.
This one.
Okay. If this is not IBUS OCT, it might be more clear. Okay, from here. Okay. coming. Huh. 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 Okay. Then I will do IVAS to diagonal.
So, do we have any opinion from the panel about the ultrasound findings?
No pericardial effusion.
Yeah, it's a very important finding.
Distal LAD size increased a little bit, and the symmetricity become better, and I think the proximal, there are only one strut comes out to the left main, but
Okay.
there are no problem, right?
Start. I was.
IVAS from the diagonal.
So, IVUS in the diagonal now.
LAD is coming. That is metal carina. Okay. Okay. So how do you think? I think the result is acceptable.
Yes, yes. Result is acceptable, right?
So
I think by angiography it's going to look even more than acceptable.
I can remove the wire to this moment. Maybe can do. Okay. Okay. Just short. And epicrania. Okay. Okay, I can finish.
Well, that's
Thank
a
you.
beautiful
Thank you.
result.
Thank you.
We're very, very impressed, and the patient
Thank
will be
you.
very happy.
Thank you.
Congratulations.
All right.
Congratulations, a wonderful result. Thank you very
Thank
much.
you.